Good morning, everyone. We're going to give everybody another minute to jump on. And it is definitely a day that requires hats, coats, and warm outfits as we are not in the same weather climate as Dr. Nicholson. I am Dr. Stephanie McNally, and good morning. I am the Medical Director and Vice President of Clinical Initiatives, Patient Experience at the Katz Institute for Women's Health. Thank you so much for joining us this very chilly and holiday festive day for the Mary and Richard Slone Grand Rounds. At the Katz Institute, our mission is to improve the health of women across their entire lifespan with one single focus: women. The Institute provides complete healthcare connections and defines the standards of excellence in patient centered women's healthcare. We are advancing in terms of our mission and alignment. The Institute is that convener, that amplifier of all things across our Northwell footprint that are bringing initiatives together. We are focused on improving healthcare outcomes for women, and ultimately, with a healthier woman, there are healthier families and healthier communities. This is the core of what we do, from education to experience to outreach. We are the ones listening. We are the trusted voices. We want to really think of how we got here today, and an incredibly special thanks to Mary and Richard Slone. It is their generous support for this program. They have been longtime supporters of Northwell and women's health. These grand rounds are giving us the opportunity to educate current and future generations of healthcare providers on the latest advances and really that scientific breakthrough in the field of women's health. How do we look at things differently with the patient at the focus? So for all attendees today, we want to make sure that you get your CME credit for the incredible grand rounds that we're going to hear. Northwell Health is jointly accredited with the ACCME, ACPE, and the ANCC, so to provide continuing education for healthcare professionals. At the end of today's program, we will share a link, so you should complete the evaluation and claim your credit. As a reminder, 2 days is when we need to have you complete this, and your feedback is important as we drive continuing education opportunities for the future. The following is Northwell's disclosure policy. Northwell adheres to standards for integrity and independence in the accredited continuing education forum. Individuals who are part of this program are requested to disclose financial relationships. All planners and speakers for today's program have done so. Throughout the talk today, please use the Q&A feature in the webinar, and we will have a moderated discussion after today. So please put that in, and we want to, again, you see our disclosures here. So today, we are here to welcome Dr. Wanda Nicholson. Dr. Nicholson is a professor of prevention and community health at the George Washington Milken Institute of Public Health and professor of obstetrics and gynecology at George Washington School of Medicine and Health Sciences. She is the former director of the Office of Inclusive Excellence at Milken. Her research portfolio focuses on the development of innovative healthcare delivery models for chronic disease prevention, particularly among vulnerable populations, with focuses on type 2 diabetes and cardiovascular disease. Her goal in research is translating into clinical care. With federal and private funding, she's adapted evidence-based lifestyle interventions proven in non-pregnant persons for then those patients that are pregnant and postpartum. She's using digital platforms to engage patients, meet them where they are in terms of their care with diabetes, and molding the research connects with them for a healthier life. This is the core of what she does. On national and international levels, she has served as the chair of the United States Protective Task Force and held board and volunteer leadership roles at the American College of Obstetrics and Gynecologists, the American Board of OBGYN, and the International Federation of Obstetrics and Gynecologists. It is with great pleasure and honor that I welcome Dr. Nicholson. The floor is yours. We are open for learning and innovative ideas.
Stephanie, thank you so much for that. Let me just see if I can go back through the steps and share my screen. And give me 1 second that I can get that correct.
Excellent. I think we just need to put it in that presentation mode and we should be good to go. Awesome.
Okay. One
Welcome.
second. Just let me try it one more time. Give me 1 second. I'm sorry. Here we go. I think we're good. Well, first of all, let me just say thank you for that incredibly warm welcome. And let me just say it is just an honor and a privilege for me to have been asked to join you all today. I certainly follow the CATS Institute. You all are all everywhere on social media. And I certainly tend to follow you most on LinkedIn to keep up with what all the different activities are that you're doing. And Stephanie, certainly what you talked about in terms of the mission and vision of the CATS Institute so totally overlaps with my both my individual mission as well as the mission of our research team and moving forward to advance women's health. So it truly is a pleasure and an honor to share this time with you all this morning, and I've been looking forward to it. I also just want to give a major shout out to Rosanna for all of her help over the last couple of weeks in getting me ready for the presentation today. Thank you so much. I do want to spend the time that I have with a brief focus on advancing women's preventive health through innovation, through three cores: innovation, evidence, and patient informed. And just a few disclosures here, as Stephanie mentioned, I'm the immediate past chair of the U.S. Preventive Services Task Force. So certainly views expressed in this presentation would be of my own and should not be construed or thought to be any official position or thought from AHRQ or the Department of Health and Human Services. Just the first couple of slides here are really to sort of set the landscape of what I'd like to talk about over the next 40 to 45 minutes. And I know that we are all well aware of the important roles and contributions that women make both in the US and globally. But whenever I do this talk, I always feel that it's worth just taking a second to just really reflect on the enormous input and contribution of women. We're key drivers of the economy in the US and globally. We are family. We are mothers, we're sisters, we're friends, we're co-workers. Not only that, we're community leaders and teachers. So we're affecting not only our own generation, but future generations. And of course, we're always engaged family members. And in many cases, we're multitaskers. We're not only taking care of our immediate families, but also taking care of our extended families, family and the elderly. And of course, all of these efforts, all of these major contributions start with having good health and sustainable access to healthcare services. So in that framework, I'd like to focus today on sort of three objectives, but I will say that, my overall take-home message or mantra, I would say, is, how do we best continue to infuse innovative technology into practice so that we can continue to deliver evidence-based care that is certainly on the pulse of new technology, but also, as you'll see here as I wrote, informed by patient and community engagement. So I think all three, I'm hoping that will resonate throughout this talk, that all three components, the technology, the evidence-based care, and the patient-informed or patient engagement are key factors. I have three objectives that I hope to cover in the brief time that we have together. The first one will be the primary objective, which is to look at and reflect back on common roadblocks to what I will say is specifically postpartum preventive care, which is what I tend to focus on, and how access to care can be improved with innovation, particularly innovative digital technology and tools. Secondly, to be very proud and excited about the fact that as a whole, we continue to examine the impact of innovation and emerging technology on prevention screening, which is so important to women's health. And I want to briefly use the case of cervical cancer screening with some recent updates. And finally, really to sort of bring this all together to say that no matter how much we're using technology, how much we're moving forward with prevention or prevention screening, we can't do it as well as we need to do it if we haven't engaged our patients so that they can help to inform not only prevention research, but really inform the clinical experiences that we're having and engaging with them day to day in the clinical setting. So just briefly, just a few background slides. I mean, we're all aware of the continued concerns around maternal mortality rates, both by race and ethnicity in the U.S. You see here within this red circle that as we look across different racial ethnic groups, the data continues to be concerning. We still have Black women who are 3 times more likely to die in pregnancy or childbirth compared to other racial ethnic groups. So certainly, there definitely needs to be a continued movement forward in addressing this morbidity and mortality. And I would say, perhaps, particularly as we focus on postpartum, how digital technologies can really help to make a difference. One of the ways to look at decreasing maternal morbidity and mortality, and I know that we tend to have a large, substantial amount of our focus, and appropriately so, um, during the prenatal care period, pregnancy period, as well as during delivery. And these are important, equally important phases of the perinatal process. I certainly want to give my hats off now to Stephanie Fitzpatrick, who's also part of you all in the CATS Institute, and the wonderful work that she is doing with the Moms Chat Study. I'm a member of her steering committee, and she's doing wonderful work focusing on pregnancy, delivery, and the immediate postpartum period. But as you see here on this particular slide from the Commonwealth Fund, you're looking at going from conception through pregnancy, delivery and birth, and afterbirth. And if you look at those at the graph at the bottom, you'll see about 31% of um, pregnancy-related deaths occurring during pregnancy, the 17% on the day of delivery. And then you have this range of 12 to 21% across different phases or different periods of the postpartum period. And I think that it's really important that we draw attention to that again, not to diminish the morbidity and mortality that takes place in pregnancy and on the day of delivery, but looking here that 50%, this a total here of 52% postpartum deaths. So in other words, 52% of those deaths occurring after birth. Um, some occurring in, as you can see here, days 1 through 6, which are the immediate postpartum period, but also additional percentages of death occurring further out in that 7 to 42 day period, and then ultimately in the 43 to 365 day period. So certainly, as we move forward and with our evolution of recognizing the breadth and depth of perinatal morbidity and mortality, it's important for us to look particularly at all phases. Um, Similar to that is sort of the question, it raises the question of what do we do differently? We know that during pregnancy and during delivery that we have our patients who are sitting there just right in front of us for our care. Whereas once they exit the hospital, there is this geographical or time distance that we need to sort of compensate for or readdress if we really want to reduce the maternal morbidity and mortality that occurs in that postpartum period. And there have been efforts to do so. If you look here, you'll see that there's been multiple strategies and advocacy put forward. The World Health Organization, for example, has advocated here immediate follow-up post-delivery. Within the first 24 hours, another follow-up at 2 to 3 days later at the 48 to 72-hour period, as well as follow-ups between 1 week and 2 weeks out from delivery, and then another follow-up at 6 weeks. And these are all efforts being put sort of broadly globally to try to address that postpartum maternal morbidity and mortality, which I believe is so important and which is a central core of my focus in research. But we also know, unfortunately, that even in the US, only about 30% of mothers attend that 6-week postpartum visit. And this is across different racial ethnic groups. It's across different insurances. You could have Medicaid versus Blue Cross Blue Shield insurance. And we still have low attendance at this important visit. Some have raised the option of certain alternatives, including home visits, which have worked well traditionally, but can be very expensive and may not be able to provide the amount of reach that is necessary to really make a difference in maternal morbidity and mortality. Certainly, our friends at ACOG have been pushing this topic as well with the fourth trimester project and beyond. And I listed here the committee opinion. This is still very much in place, really emphasizing that after delivery, that fourth trimester is important not only for assessing women for quality of life measures, bonding with the baby, these typical postpartum issues, but really being on the lookout for potential risk factors for cardiovascular disease and outcomes, as well as whether there are moms who may not have been thought to be developing type 2 diabetes after a pregnancy complicated by gestational diabetes, and are we having women who are therefore with emerging or evolving unrecognized conditions that are being missed and therefore not treated, and ultimately resulting in maternal morbidity. I think part of recognizing this time period, this postpartum time period, which is really, let's say, 6 weeks up to 1 year, is a pretty long time period. There's many activities that take place in the home with the mom returning to work, other factors, family commitments that take place. And I think it's also we have our patients who are really at that same time, they're sort of not in our, I would say, that cocoon of prenatal and pregnancy care. They're sort of outside of that warm cocoon that we create for them within the healthcare system, and therefore they're exposed to many of the other potential roadblocks to care that non-pregnant or otherwise other adults are also experiencing. And it's important for us to maintain our awareness of these. One, of course, are medical deserts and rural closures. I'm sitting here in North Carolina today, my home state. I'm sitting in a fairly urban area with multiple academic institutions around me at the tip of my fingers. But if I were to drive roughly 45 to an hour away from where I currently am, I would basically be in the middle of one of these medical deserts and where rural closures have taken place. And so while sometimes we're not visually seeing these entities, certainly they are occurring. There can also be ongoing fragmented coverage and gaps in care. Certainly, disrespectful care has been an ongoing, I think, cultural and equity issue within our specialty. Certainly, the lack of patient-centered care, not only the effort or the lack of effort to balance what we know medically with what the patient's wishes are and coming to a medium around those issues. And I would say sort of an emerging area that's important for all of us to address and be aware of for our patients upon delivery are information gaps and misinformation. And this is unfortunate, but certainly we are in an era where gaps in information and misinformation can unfortunately take our patients down a pathway that's not the best pathway for their care. So certainly important for us not only to recognize these roadblocks, which I think that we do, but also to really think very strategically about how do we help our patients to navigate these roadblocks? How do we think strategically, research-wise, implementation-wise, in a way that we can partner with our patients and help them to navigate these roadblocks and maintain a high quality of care, particularly in the postpartum period. Oops, sorry about that. With the wrong way on the dial. So part of what we are um, have been focused on doing both during my time at UNC and now during my time having transitioned to the George Washington University is to move forward in this respect, to um, help facilitate pathways to help patients, particularly in the postpartum period, where there's not that ongoing connection and visits with the healthcare system, to navigate these roadblocks, to maintain and sustain a certain level of quality of care is hopefully to improve outcomes. And that's what our goal is in the Power Lab. And this Power Lab is our prevention science outcomes in women's reproductive health. And one of our key missions is to try to expand postpartum prevention care using digital tools. So, in other words, focusing on those women who we know are at high risk, particularly for cardiovascular disease or for developing type 2 diabetes. So, women who during pregnancy may have had a hypertensive disorder of pregnancy, such as gestational hypertension or preeclampsia, or on the other hand, may have had gestational diabetes. We know that subsequently they're at risk for these chronic conditions. So our goal is, how do we integrate digital tools to enhance postpartum prevention and ultimately to prevent chronic disease in reproductive age women? How do we keep our reproductive age women as healthy as possible going forward in life? And you might ask, well, um, how can really pulling forward or moving forward with digital interventions make a difference? And again, I think my take home point to you all would be they can help to navigate roadblocks to prevent severe maternal morbidity and chronic disease. And let me say that, and I say this often to my clinical colleagues, is that as we move forward with digital tools and its emerging technology, of course, there are pros and cons. And I would advocate that a major pro is to expand access and ongoing health delivery. But we have to recognize that the goal here is not to replace any of us. I certainly believe that there's nothing more important than the patient-provider relationship, and that relationship that you establish with them over decades, or one that you establish with them over the 9-month period of a pregnancy. And I will always be so grateful for those experiences that I had when I was, highly clinically active. So using these digital tools, the goal is not to um, diminish that relationship, but rather to provide an opportunity for the information, the guidance that you as a provider can provide to patients, having the digital tools be an extension of that when the patient is not in a position to be able to come into the office to see you on a regular basis. So we would say it expands access to interventions for high-risk moms, particularly where there may be in limited clinical areas, promotes continuity and partnership in care, and delivers a highly specialized, scalable service that can be personalized and tailored to the mother, which I think is very important. And again, getting back to the issue of misinformation, this can be a direct tool for us to counter misinformation that our patients may be seeing on social media in a direct way through digital technology. Just quickly here, we know that, and I'm focusing here on gestational diabetes mellitus because gestational diabetes is one of the key factors that we focus on as part of the Power Lab. And we all know it can be a window on the future and definitely is a call for diabetes prevention, given the potential risk of developing type 2 diabetes without important lifestyle modifications, and the fact that gestational diabetes and evolving type 2 diabetes certainly puts the patient at risk for cardiovascular disease. So I just want to take a moment to just quickly walk you through what the Power Lab has been doing over the last several years with regard to focusing on the particular population of gestational women who've had gestational diabetes, and what our goals and steps have been to try to really move from research that's effective and shows results to our ultimate goal of being able to therefore then integrate a particular program or model of care into the actual clinical setting and where we are, on that journey. Just briefly here, we started out with what I call Good Moms version 1, which was our initial efforts to take the diabetes prevention program that was so well established in non-pregnant adults and really modify it to an extent to really cater it, so better catered, I should say, to postpartum women at risk for type 2 diabetes. And we did this study back at around 2014, 2015. You can see there on the left, what we did is not only did we modify the original diabetes prevention program lessons for lifestyle modification to make them more aligned or attuned with postpartum women's needs and efforts. But we also developed an online portal for postpartum women to really be able to access these materials um, on their own time schedule, and then have intermediate webinar meetings with us. And so this was what I would say was a single arm intervention with the online portal webinars. And we also post the study, also conducted some post intervention interviews. So in this study, we had a baseline group of women who we took baseline measures on. We put them through this 6 month intervention and then did follow up measures. And we did have, I think, important, although modest, postpartum weight loss. We certainly had improved depression symptom scores, and we also had higher physical functioning. What we also found out through being informed through these post-intervention interviews was the need for future steps. So this was a smaller study. Our next step was, which I'll get to the next slide, was to then compare this intervention that we call Good Moms to standard care. And you'll see ultimately our goal is to then compare lifestyle to preventive medications such as metformin or the GLP-1 agonists. And then our ultimate also future research goals was to figure out, is there a way, after all of this work, is there a way that we could finally make that final important step of integrating it into clinical care? But this was Good Moms 1. And Good Moms 2, we did actually move forward with a clinical study. We conducted a small, pragmatic, randomized trial. Ultimately, our results showed higher physical activity self-efficacy on the part of our participants. In other words, by going through our intervention, they felt like they had more self-empowerment to maintain consistent physical activity in the postpartum period. They also had better dietary intake. As you can see here to the left, we made some further adjustments to our digital tools. We expanded the portal to include a whole host of lessons, both for the mom as well as for the father and the family. We had additional tips about how to maintain a healthy lifestyle while taking care of a growing family. And then we added, as you can see here at the bottom, a tracking tool so that women were not only able to track their blood glucose levels, but also their blood pressure levels through some remote blood pressure monitoring at home. So again, this represented not only an expansion of the portal, the digital tools, but also gave us an opportunity to compare the intervention to standard care. We did this among, if you can see under Project AIMS, the results among 50 women who were diagnosed with GDM. And I think that part of the importance of this study is that it wasn't focused just on postpartum. This particular second version started in pregnancy and then went through the first 6 months postpartum, with our goal being, is there a way to start in pregnancy, form that relationship with the study, and continue in a pretty seamless fashion up to 6 weeks postpartum for a wider range of care. And we looked at several parameters here, including hemoglobin A1C and gestational weight gain during pregnancy, as well as looking at weight loss in the postpartum period. And what we found some modest results again in this study that the Good Moms intervention was helpful in maintaining a healthy weekly rate of weight gain by our participants. Our participants, again, as I mentioned earlier, also had higher reported physical activity, both during pregnancy as well as postpartum. They felt more empowered to exercise and also had better dietary intake overall. What we also found, though, is that there was very little difference between their hemoglobin A1C or depressive symptoms. And particularly in the postpartum period, their weight loss was fairly similar actually between the intervention group as well as the usual care group. But again, we felt like we had some important results to be able to move on to the next phase of study. And this particular project did show us that we could randomize individuals to the intervention or the usual care group and maintain and sustain appropriate follow-up. So this brings me to where we are currently, and I guess you could call this perhaps version three of the Good Mom study, but this is uh, our gestational diabetes study, a biobehavioral study. And very, very proud of where we are now with some funding from the American Diabetes Association. As you can see here, this is a collaboration between my School of Public Health at George Washington University, the School of Medicine, my colleagues back at the University of North Carolina at Chapel Hill, and also a large national advocacy group, Diabetes Sisters. So Diabetes Sisters has been in existence for over 20 years. Actually began as a community advocacy group right here in Durham, North Carolina, and is now nationally based. And so they have been a advocacy group representing patients living with gestational or any other type of diabetes who have, who are co-investigators and have been ongoing consultants on this current biobehavior project. So what's our goal in this current study? Our goal in this current study is to move forward with where technology is currently happening. So our goal here is to compare two lifestyle interventions, again, based on diabetes prevention programming that we've worked with in the past, but then to compare it to medication. And in this study, we'll be comparing it to metformin, a drug that's been around for decades that can be used to prevent the onset of diabetes, but also has been used for weight loss in the general population. So we're comparing two interventions to metformin on postpartum weight loss in moms in the postpartum period who had gestational diabetes in their most recent pregnancy. And you can see here we're looking at a wide range of outcome measures, including weight loss, change in A1C, blood pressure, and as well as some mental health measures in terms of depressive symptoms, quality of life, and client satisfaction. So this is our newly developed study, again, trying to mirror or align our research efforts with also the changing environment of how we're managing obesity and diabetes in the general population. And let me just say quickly that with this particular design is an adaptive study design. And you look here, and I realize that this graph is um, a bit involved, but all of our participants will receive the lifestyle intervention initially, and then we'll have them on the intervention for an initial 4 week period, and we'll see if they respond with a 2% weight loss or non-respondents. If they if they respond, they'll continue on the lifestyle intervention. If they don't respond, we'll randomize them to what's called an enhanced intervention uh, versus metformin. We then also have a follow-up wait at 6 weeks again to look to see if they have reached their threshold goal. And if not, at that point, we'll have a second randomization to either the continued enhanced lifestyle intervention or randomization to metformin. And the goal here for this adaptive study design is to really reflect what goes on clinically. Our goal is for all of the participants to initially have access in the postpartum period to the lifestyle intervention, but also recognizing that for some postpartum women, it is easier to lose weight than others. So if you're successful, you continue with lifestyle. If that wasn't successful, you continue with that enhanced version of the lifestyle intervention, or you continue with the lifestyle intervention plus the medication with metformin. I won't belabor this particular slide. It's just another infographic um, outlining what was in the previous slide. As part of this intervention, we offer and provide digital scales so that women can weigh themselves at home and reflect it back to us at our coordinating center. They also are equipped with Fitbits as well. And just briefly, this always begs the question of why metformin and not the GLP-1 agonist, and happy to expand on that in the Q&A session. But our goal is that once we finish this particular study, to look at the next phase as incorporating, rather than metformin, potentially incorporating GLP-1 agonists in postpartum women. And just quickly here's our list of eligible participants, but largely they are women 21 to 45 with the BMI that you see listed there and a recent pregnancy with GDM. We want to focus on women who had GDM but also delivered basically at term and who are actually 3 months to 12 months postpartum, so a wide range of time period for potential participants. Currently, this intervention is for those who are English speaking, who can provide consent in English. And again, we'll also screen to make sure that their infants have no major birth complications. Let me just skip forward quickly here to say that we're very happy with the efforts that we've been able to make so far in the study, particularly this biobehavioral study. We recognize there are going to be some challenges, potential hesitancy about taking medications. We've already seen some of that, particularly among those women who are breastfeeding. We also know that there's continual challenges for new moms in terms of balancing work, childcare, and family commitments. And there is new evidence of potential weight gain even after continuation of GLP-1s or metformin for, for weight loss. But again, uh, certainly we are ecstatic, certainly grateful for the funding from the American Diabetes Association and looking forward to additional work in this particular area on the perinatal side. Let me let me pause here and shift gears. I don't want to only talk about perinatal pieces, although that is the primary focus of my research in the Power Lab. I do think it's important in this era of emerging technology and certainly the excitement around it to have a word or two around moving forward on the GYN side or the general women's health side. And this gets to advancing evidence-based, patient-centered, I would say, prevention in the case for cervical cancer screening. Um, I won't belabor this slide. I know that we're all familiar with cervical cancer. Just some key points in terms of the burden here that we know that deaths in the US have dramatically decreased with widespread cancer screening. Most cases of cervical cancer occur among those women who have not been adequately screened or who have had challenges in getting access to screening, and that really is the crux of the matter. We know that there can also be disparities in morbidity and mortality because once women are screened and screened positive, sometimes their insurance or other barriers can interfere with prompt diagnosis and treatment. And while cervical cancer deaths have certainly decreased dramatically, we know that it's still an important topic. In 2024, there was an expected over 13,000 new cases of cervical cancer, and there was an expected over 4,000 deaths in 2024. As Stephanie had mentioned, one of my prior roles was chair of the United States Preventive Services Task Force. I'm now an immediate past chair. And in that last year, we reviewed the updated data on cervical cancer screening and the new technology. I won't belabor this particular slide, only to say here's a picture of the current task force members and that the task force is still actively engaged in activities around evidence-based recommendations, focusing on screening, counseling, and preventive medications. And screening for cervical cancer has been a part of the task force's portfolio for many years. Just briefly here, I'll say just briefly that the task force puts out graded recommendations. I've highlighted here A and B recommendations because A's and B's are the ones that we definitely want to do in our primary care settings. But getting to cervical cancer screening, the task force issued a draft recommendation on cervical cancer screening in December of 2024. The final recommendation is still pending at this stage. And recently, you all may have also seen some similar guidelines that were recently published by the American Cancer Society. And I think before I get into what the recommendation is saying, I just want to say that the important piece here is that we have wonderful technologies and ways of screening for cervical cancer. I think the important take-home point here is that while we currently have had wonderful ways and a couple of different opportunities for cervical cancer screening, that the technology, the focus and the commitment to that technology has continued to thrive and move forward. And we have even better screening tools currently that we can use for cervical cancer screening and that can also expand access to screening. So if you look here, we're saying for women ages 21 to 65 in this left-hand column, that we're recommending cervical cancer screening every 3 years with cervical cytology alone. That's the same pap smear that we've always used. That's still a viable option. It's still considered an A recommendation, which means that it's highly impactful. And that is in women 21 to 29. And then every 5 years, with what we're saying now is clinician or patient collected high-risk papillomavirus, HPV primary screening in women ages 30 to 65. So in other words, primary HPV screening is now considered the preferred method of screening for those who are 30 to 65 years of age. You can still, many of our institutions are still continuing with co-testing, which is still a viable A-grade recommendation for screening, or you can still continue with our traditional pap smear. So all three options are A grade. We do know that the primary HPV screening has a slightly higher accuracy than the other two options. So that's why it's considered the preferred screening. But I think the important take-home point here is that it says clinician or patient collected high-risk HPV. So in other words, with new technology, um, our patients can continue to come into the office and have a pap smear that's collected by their clinician, that's clinician collected. They could also do on their own a vaginal swab in the clinic, in the exam room, in a private exam room. And this based on new FDA approved technology. And then third, there's also the option now for home vaginal swab collection through an FDA approved device where women who are in rural areas, let's say women who may have certain disabilities, who have difficulty getting to a clinic, can now do a vaginal swab at home and have that swab mailed in for primary HPV screening as well. So now the ever evolving technology, which is very exciting, not only continues to improve cervical cancer screening, but also expands the potential access. So you can see here in summary, the task force's proposed changes is that our preferred strategy, although there are multiple ways, the preferred strategy is HPV screening every 5 years. And again, with the FDA approved technologies, now there's the availability of clinician collected in the traditional way or patient collected HPV screening through FDA approved devices. I'll quickly say, I know we have limited time, that this evidence supports different approaches to screening. And again, the patient collection can increase screening in certain patients. Certainly, the self-collection of the vaginal swabs can expand access in rural areas, or those women who don't have readily available access to a provider who can do a pelvic exam, or who have difficulty just getting in the position for a pelvic exam. In the few minutes that I have left, and I'll shorten this piece, is to say that regardless of whether it's digital tools for perinatal and postpartum care, whether it's emerging, evolving, exciting technology for prevention screening in the case of cervical cancer, none of this is going to be truly possible and sustainable if we don't also hear from our patients. And so this last bullet point or area that I do want to focus on just quickly is the goal of engaging patients' perspectives for preference-sensitive, patient-centered care. And what I would advocate and what we have integrated into the research program of the Power Study is this bidirectional conversation between patients and health systems to level set expectations for care. You have patients sometimes who are not feeling heard. We talk a lot about this within ACOG. On the other hand, you also have clinicians who, for better or for worse, are not always offering the most optimal approaches to patients. And there really needs to be some level setting to align patient and provider expectations. And you may say, well, how can we do that? I just want to close out with two examples. One example here is one that was funded several years ago by the PCORI Engagement Award. What we did in collaboration with UNC and Hopkins and an outside company called Trust MD was we developed an online portal, again, for women with any type of diabetes to log on and verbalize where they thought the gaps in knowledge was for the healthcare system and providers, and what research they thought needed to be done to help them to live healthier and longer lives. And so we built this portal It stayed online for about a year. We got just such a wide range of information and input and perspectives from patients actively living with diabetes as to where the next research agenda or portfolio should go. And this was very, very enlightening and has continued to inform and impact the studies that we've done as part of the Power team. A second one I want to mention here is on the GYN side, and this was also funded by PCORI. It was focusing on women with um, uterine fibroids and their options for surgical intervention. And again, if you see the picture here, there's two researchers here to the right, Dr. Ebby Stewart and Dr. Shannon Laughlin. But to the left is Sateria Venable, who established the Fibroid Foundation, a patient-founded advocacy group. And so we collaborated with her to help us actually revise the um, aims and objectives of the study, to work with us on our methods, certainly to work with us on how we went about recruitment. So I truly believe that as we move forward with new technology and new ideas, having patient-informed research is going to be crucial to having success, not only in the research being completed, but with the research being implemented. And so let me just quickly say that I strongly believe patient-informed research can improve practice and improve care. As clinicians, we largely know what to do, but I think our patients can really help us to know how to do it better. And I think in many cases, we recognize that there's gaps in our clinical knowledge. I think we need patients to tell us, out of all those gaps in our knowledge, which ones are most important to them. And the only way to do that is through patient engagement and patient-informed care through the avenues that I've showed you that we've done in the past. So let me just say, to summarize, digital tools can certainly help us overcome roadblocks to care. They can be scalable based on practice size and patient characteristics. Apply new technology, like in the example of cervical cancer screening, advances prevention care. We don't need to sit back on our laurels and say, well, we have enough preventive technology. We do need to keep striving, working forward, and this is important to see. And finally, talking with patients about what they need and what they want can help to improve the quality of care. So just in closing and coming full circle, I'll still say that my baseline message to you all is we need to continue collectively across the country as providers to continue to infuse innovative technology into practice to deliver evidence-based care that's also informed by our patients. We need to continue to talk with leadership about integrating scalable digital tools into practice, into our EHRs. Continue to learn and leverage technology to advance prevention care screenings and services. And always continue to create pathways for ongoing patient to provider conversations and dialogue. And with that, I'll close with this final slide. Just wanted to show parts of my power team. Across the top is the power team that's located with me on site at George Washington University. At the bottom are our collaborators, the three collaborators that I still maintain a close collaboration with at UNC. And to the bottom right is Ms. Donna Rice, who is the CEO of Diabetes Sisters, our advocacy group that has continued to provide the patient-informed messaging and input that we've needed to develop our research program. And I'll stop there and thank you for your time. And again, thank you for the invitation. Happy to answer any questions.
What an incredibly thorough overview, and then with such specific details about really meeting patients where they are. So there are a few questions that have come in. We want to start with our executive leader, Dr. Rosen's question, really about the thoughts on initiatives to better address that postpartum piece with hypertension, and
Right.
how do we incorporate some of the work that you're doing in targeting that reduction, because we know that lifetime risk is real.
Well, first of all, Dr. Rosa, thank you for the question. And I certainly have been following you and listening to your presidential address from the AHA. So I am ecstatic to have you on the call today. I think that we can mirror this. I mean, I ended up falling into the realm of gestational diabetes because I just, for some reason, clinically, I just always seem to have a patient with gestational diabetes. So that's how I landed here. but we know that that can be a risk factor for cardiovascular disease. But most importantly, getting back to Dr. Rose's point, I'm sure that's what she's thinking is that, hypertensive disorders of pregnancy are first and foremost a key priority. And if we can combat that and create a pathway in the postpartum for follow-up surveillance and intervention, we really can make a dent in the maternal morbidity and mortality that we're seeing. So I would say in a similar way is that in terms of the AHA and their emerging and evolving guidelines for postpartum surveillance and intervention, that number one, um, further ensuring the reach of those guidelines to a whole host of different types of providers, not just the cardiologists and the internists, but my colleagues in OBGYN being more up to speed on what the AHA is recommending so that we can integrate that into clinical practice. But I think also in terms of the digital tools, being able to, and I'd love to work with someone on this, taking what we currently have and modifying it with a more of a being or emphasis on the cardiovascular disease side. That could easily be laid upon our existing platform that we're using. We can basically develop some recommendations and web lessons for patients that can be laid upon our current existing electronic platform, look at what cardiovascular outcomes we want to measure going forward in time, and easily transition from easily maintain our diabetes specific one, but also mirror or create a partner one on the cardiovascular disease side. So I certainly would be interested in that and think that that would be a great opportunity. Again, I would say that part of the goal of the digital tools is for the ongoing outreach for the provider to the patient in those interval times when the patient's not able to come into clinic, so to maintain and sustain that care.
It sounds like we're going to have a lot to collaborate on from the endocrine to the cardiovascular. We're going to keep you very busy. One of the other questions that came up in terms of obviously the GLP-1 discussion is very important is are you going to one stratify patients on which GLP-1 they would get based on their
Oh,
health needs? And then the other piece would be to
I am.
track, I think if we can just mute everybody. If the other piece would be
It
then
was good. Everything went quickly.
hold on,
It's
sorry about
finally
that.
to the end
Well,
of the
that's a,
year, but
no,
Hold
no
on,
worries.
sorry about that. Um, would be to then look at C-section rates because the NTSV situation, we're trying to minimize C-section rates. Are you looking at that as an outcome? So one, stratifying what medications patients would get in kind of the next iteration. I guess we call it moms, good moms point 3.0, 4.0. And then on that point, are we tracking C-section rates, especially for first time pregnant persons?
Well, with regard to the first question, you're actually right on the pulse of what our research team has been contemplating, debating, arguing about in a professional way as to which way we should go. Um, and certainly recognizing in the interim time there may be even some additional GLP-1 agonists that come on the market. Um, so we are contemplating that idea. Do we stratify by which ones that you're on? Um, I think that definitely would be the more pragmatic approach. I think logistically it makes it a little bit more difficult because it requires a higher number of participants that would need to be enrolled. So I think it's an important factor that we're going to have to look at more closely and work with biostats as to how we could balance that. So definitely a question for us to continue to ponder. And yes, looking at the cesarean section rates would be critical. I think going forward also we also want to add some more um, patient reported outcomes to the delivery process. So not just cesarean delivery, for example, but getting at some questions that would better assess the patient experience as well. I think that's going to be more of the patient reported outcomes need to be added to our future work.
I love that idea, not only because it does put that patient at the center, but thinking about how long will it take somebody who's trying to conceive to get pregnant based on these interventions, and then that really then impacts their mental health, their well-being, and kind of how that health impact also then from a bigger perspective. So you'll be getting a phone call from us at the Cats Institute for sure.
I would love that. I would love to have that phone call. And let me just say that these debates that even my current research team is having on whether to stratify by the type of GLP-1 agonist or how to do it. I mean, we go on for for hours about that, so I quite enjoy that. I mean, that's part of the stimulation and the excitement of the research, but also the commitment of getting it as right as we can to help women move forward. I'm just very, very excited. There's so much going on in women's health right now that I think is just great. I'm hoping that the focus stays there. Not that I don't care about men or kids. I certainly care about I care about everyone. But it really is exciting to see things moving forward, both in the OB world as well as in the GYN world. I know we didn't talk about menopause today, but I mean, it's
Oh,
just so
that's my
much.
jam. That's my
Yeah,
favorite
yeah.
topic.
So it's just so much going on that it's just exciting and very satisfying to see it for our patients going forward. Let me just say that.
We couldn't agree more, and it's that multidisciplinary approach that really is going to move the needle. One question came up about how do you best tackle a conversation with patients to break down misinformation? I know that's a really broad topic, but there's so much out there that is not guided in science. What would be a take home for our team of how to break down some of that misinformation? Or is it different depending on who you're talking to?
I think it can vary. I mean, I think depending. I mean, there's some patients who have read the article, the same article that you've read. I mean, so it certainly varies. But I think that my focus has been to really kind of start with where did it come from? What's the real underlying concern? And sometimes it's a matter of just simply asking, well, tell me more about what you're saying. Um, where did you get the information? Was this something you read? Was it something that you discussed with your family? Because family dynamics can play a key role. So part of it is really getting a better idea of the background of where the person got the information. I think it gives me really a clue in better on how to approach it. Plus, I feel like it gives the patient an opportunity to really take the floor and feel like I'm hearing them and let them explain to me what they're thinking. I think part two of it is really getting versed on what their underlying concerns, what is their worry. Even if their worry is a false worry, it's a worry, and we're going to have to find a way of moving past it. That's just the bottom line. And then I usually come back and say, well, let me tell you what we know and what we don't know. And based on what we do know, I would say that I respect what you're feeling and what you're saying, but it's not actually correct, and let me offer an alternative plan of care for you and I to now consider and talk about. And sometimes that works very positively. Certainly, it doesn't always work with just a one-time conversation. I mean, even in this day and age, I've had to have multiple conversations around the flu vaccine. Um, even in 2025, that's I still have patients who decline despite however I communicated. So I think my goal has been to really try to hone my skills on being the best communicator that I can. At least I can feel that I've expressed it as well as I can to the patient, and then respecting what their response is. And ultimately hoping to guide them in a way that even with the misinformation that they have, that we do no harm, that they don't inadvertently go down a pathway that's going to be a threat to them or to their unborn child.
I think that is a beautiful place to end in terms of actually, and this is part of the core of the Cats Institute mission and exactly what you're doing, Dr. Nicholson, is listening to your patients, giving them the floor to speak, ask questions, and truly, truly meeting them where they are. So much great information. We cannot thank you enough from across the whole women's health space, the Northwell community, and I'm sure it's a lot warmer where you are
Well,
than where we are.
it's only about 28 degrees here, so I'm not sure.
We'll take it. It's 17 here this morning. So thank you again, and you will absolutely be hearing from us. Again, we want to thank everybody for joining our conversation today. Please do not forget to fill out your CME credit. The lecture series will be kicking off in 2026. I cannot believe we're saying that.
I
That will
know.
be we're back to the even numbers right now. So February 10th, our guest speaker will be Distinguished Professor of Medicine and the Judith and Joseph Wagner Chair of Women's Health Research. We are looking forward to hearing from Dr. Regenstein, and we all wish you the best day, happy holidays, safe travels for those that you are, and Dr. Nicholson, thank you again for everything.
Well, thank you all for the warm welcome and the invite. I thoroughly enjoyed it. I look forward to future discussions and collaborations.
You will definitely be getting an email from us. Toot sweet.
Take care. Happy holidays to everyone.
Thank you so much. Be well.